Morning, everyone.
Good morning.
All right, so I sent you guys all a bingo card that I made. I figured today in class we could play this game to see if we can review a little bit. So I get that maybe not all of you can print, but whatever. As long as you can see the bingo card, you can still play. So that's what we'll do eventually here today. I did want to just mention something real quick. Um, Lisa emailed me this morning saying that the um, due dates on Realize It were not what I thought they were. So I put in a thing for IT to fix that. So just so we're all on the same page, for the remainder of the term, you guys are turning in all of your Realize It stuff, all the uh, stuff that you have to do on there by Thursday every week. And the reason I'm doing that is because since we have classes on Fridays, it just gives me an idea of kind of where you're at with the material before we have class. So anyway, so I already turned in I submitted your work for the week. So if you still had something to do, you weren't quite finished, you can finish it, by the end of the day today, and then I'll go back in and change your score if I have to, because it's not fair since the date was wrong on there. But for the remainder of the term, like next week and every other week, just noted, have it done by Thursday by midnight. Okay. All right. Is there anything that you guys went over this week that you didn't feel really comfortable with?
I think I just we didn't post the chapter 23 on the on Canvas.
What was chapter 23?
I think it was about skin. I think skin cancer or something.
Yeah, actually, I have that right here. It should be on there. Did you not see it? So under modules, yeah, it's there. There's so under module 3, there's 4 PowerPoints that I have posted there. So there's 3 for chapter 21 and then that one for chapter 23. So we'll see if we can go over it real quick now. I'll pull it up and we can kind of talk about some of this stuff, okay? And then we'll go from there. Let's see if I can share it here. You guys see that okay? Yes?
Yeah.
Okay, perfect. All right, so some of this should be kind of familiar to you because we have mentioned it before in some other classes. So we're just gonna go through and see what's what in here. So this talks about health promotion with skincare. So we want to, do health promotion practices that, give us good health regarding our skin. So our skin reflects both physical and psychological well-being, and specific health promotion activities are appropriate for good skin health include avoiding environmental hazards, attention to hygiene, good nutrition, adequate hydration, skin self-exam, and periodic professional exams for areas that are difficult to see. So when this says skin self-exam, what do you think that means? What kinds of things would you be looking for with your skin that didn't seem to look right to you?
Is it the self-exam that comes with like the breast or the testicles or whatever?
Well, we're specifically talking about skin here, though.
Mm.
I mean, so maybe seeing bruises on the skin, maybe any scratches or some sort on the skin, stuff like that, right?
Okay, sure. Now, think about skin cancer, okay? What would be things that you'd be looking for to say, oh, wow, this doesn't look right. I think I need to get this looked at.
Asymmetrically.
So,
Okay, so we're looking at moles in particular, but what about them would we be looking at?
Like
The shape.
irregular shaped,
Definitely.
different like color.
Yes, sometimes they change color. I currently have one on my back that I have to get messed with really soon here. So this one on my back, it has changed color. So like the middle part of it looks different than the outside part of it now. So they're gonna shave it off and see what it is.
Didn't you tell us you had one on your nose before or something?
Yes, that hurt like you would not believe when they took that off.
Probably
did.
just because it's on your face right there, like.
Yeah, because there's nothing right here, you know?
Yeah.
It was horrible. This one hopefully won't be as bad, but yeah, so definitely the irregular shape, you know, the skin color. Anything else that you can think of?
The size.
The size, definitely. And then sometimes, like, if you have a mole that all of a sudden it starts to bleed or it does something weird like that, which it never did before, that's always a red flag, you know? So things like that is what we're looking for. And like for me in particular, I have moles all over the place. And so it's difficult for me to see every place on my body that may have them. So like I don't even know about this one on my back. My husband saw that one and told me I needed to get it looked at. So you kind of need to have some type of surveillance of your skin all the time. So when you go in for your doctor's appointments yearly, they should be kind of looking at that for you too. Okay, then this talks about sun exposure. So years ago, we all used to like lay out in the sun all the time, right? People used to go to tanning beds all the time. You know, we did all kinds of crazy stuff that we shouldn't be doing. But now we know a little bit better. We know that we need to kind of protect ourselves a little bit more from the sun. So years of exposure to all of these UV rays in the sun are cumulative and they're damaging. So they can cause degenerative changes in your dermis. So it can cause you to look older quicker. You know, I'm sure you've seen someone who has been in the sun a ton and they just look super wrinkly and it makes them look older. The UV light is responsible for tanning, so UVB for sunburn. Both types can damage your skin and they can increase your risk for skin cancer. Prolonged and repeated sun exposure is a major factor in precancerous and cancerous lesions. And then there's something called, I don't know if I can say this right, actinic keratosis, basal cell carcinoma, squamous cell carcinoma, and malignant melanoma. These are all dermatological problems that are associated with sun exposure. Other factors that increase our possibility of sunburn include being in high altitude, being in the snow, because the snow actually reflects 80% of the sun's rays, or being in or near water can like really make you get a bad sunburn. So sun safety guidelines would be, you know, try to avoid being out in the sun in the mid portion of the day where it's the worst. Use protective clothing and sunscreen. Use chemical light creams or lotions, physical thick opaque heavy creams. And then the SPF should be at least 15. You know, if you, obviously they have way more than that now, so you could go up higher if you wanted to. And you're supposed to reapply it every 2 hours, which a lot of people don't do that, and that's part of their problem. And especially after you go swimming, because you know it comes off. So wear sunglasses, a large brimmed hat, and a darker color, long sleeve shirt or a tightly woven fabric, or carry an umbrella. I know it sounds crazy, but this stuff will help keep you from getting, you know, some of these bad issues. Okay, so patients can seek treatment for irritant or allergic dermatitis, which are two types of contact dermatitis. Irritant contact dermatitis is produced by direct chemical injury to the skin. Allergic contact dermatitis is an antigen-specific type 4 delayed hypersensitivity response. X-rays are valuable in both diagnosis and therapy, but can cause serious side effects to the skin, including redness, dry, moist, desquamation, edema, hypopigmentation, and hyperpigmentation. So yeah, we use X-rays a lot, but we have to be careful with that. Whoops, I got on the wrong slide. Also, this is talking about sleep. Sleep is restorative to your skin as well as the rest of your body. Any kind of like skin problem that you have where it's really itchy, it sometimes will interfere with your sleep because you're so uncomfortable from all this itchiness that you have. So adequate rest increases the patient's ability to tolerate itching, thereby decreasing the skin damage that you would get from scratching. Exercise increases circulation and dilates your blood vessels. In addition to the healthy glow produced by exercise, the physiologic effects are also good. It helps your mental outlook. Hygienic practices are influenced by the skin type, culture, age, and gender of the patient. The use of mild moisturizing soaps and lipid-free cleansers, as well as avoiding hot water and vigorous scrubbing, can noticeably decrease local skin irritation and inflammation. Okay, so remember I mentioned this actinic keratosis. So this, think of this along with those skin cancers. So this isn't to the extent of some of the skin cancers, like those are a little bit worse, but this is pre-malignant cells. So it's still something that you should be concerned about. So this is also known as solar keratosis. So basically you get these little papules and plaques on sun-exposed areas. So actinic keratosis are pre-malignant skin lesions that affect nearly all of the older white population. So the clinical appearance can be varied. So the typical lesion is irregularly shaped, flat, slightly red papule with indistinct borders and an overlying hard keratotic scale or horn. Because actinic keratosis is impossible to differentiate from squamous cell carcinoma, treatment should be aggressive. Non-surgical procedures are the first-line treatment. Basal cell carcinoma is locally invasive malignancy arising from the epidural basal cells. It's the most common type of skin cancer and also the least deadly. So if you had to get skin cancer, you'd rather it be this one. It's commonly develops at the site of earlier trauma, like scarring areas, you might get it there, thermal burns and injuries. The cancerous cells of this also never spread beyond the skin, and the treatment depends on the tumor location and histologic type, history of reoccurrence, and patient characteristics. The treatment modalities include surgical excision, electrodesiccation, and curettage, cryosurgery, radiation therapy, topical or systemic chemotherapy, and photodynamic therapy. This is kind of what a basal cell carcinoma might look like. Here's an example. And then squamous cell, my mom just had an episode of this just recently. So squamous cell is malignant neoplasm of keratinizing epidermal cells. It frequently occurs on sun-exposed skin at the base of actinic keratosis or another lesion. This is less common than basal cell. It can be highly aggressive and has the potential to metastasize and may lead to death if it's not treated early and correctly. So pipe, cigar, and cigarette smoking contribute to the formation of this on the mouth and lips. Immunosuppression leads to dramatic increase in the incidence of this. Renal transplant recipients, have an increased risk. A biopsy should always be performed when a lesion is suspected to be this. My mom's was on her nose, so she got hers removed. This is kind of what one might look like. So you see it looks a teeny bit different. This looks like it has a lot of like scabbiness to it. Okay, so an abnormal nevus pattern called dysplastic nevus syndrome identifies an individual at increased risk of melanoma. So approximately 2 to 8% of the white population has moles classified as atypical or dysplastic nevi. Dysplastic nevi or atypical moles are nevi that are larger and usually greater than 5 millimeters across with irregular borders and various shades of color. These nevi may have the same ABCDE characteristics as melanoma, but they are less pronounced. All right, so they do a little case study thing in here. So we have this 45-year-old white female with strawberry blonde hair and blue eyes. She works at a garden center. She has come to the dermatology clinic because she notices that her mole on her left shoulder has increased in size and darkened in color. So risk factors then for skin cancer, people who are more at risk than anyone else, it's always going to be the people who are really light-skinned. Usually they're blonde, like this person's strawberry blonde, so sure, she would be at risk. Usually it's someone with blue eyes. They have lots of sun exposure for one reason or another, and maybe even chemical exposure, like this is saying, because she works at a garden center. And they'll come back to that here in a minute. But all right, so malignant melanoma, this is a tumor that arises in the melanocytes. The cells produce melanin and cause the majority of skin cancer deaths. Melanoma causes the majority, or I just said that. Okay, more than 132,000 new cases are diagnosed every year worldwide. So the incidence of melanoma in whites has tripled in the last 40 years. Non-whites have a decreased incidence of melanoma, but they often have more advanced disease as initial diagnosis and higher mortality rates than whites. Melanoma can occur in the eyes, the ears, the gastrointestinal tract, all kinds of different places. So when it begins in the skin, it's called cutaneous melanoma. Melanoma has the ability to metastasize to any organ, including the brain and the heart. Although the exact cause of melanoma is unknown, the combination of environment and genetic factors is usually involved. UV radiation from the sun is the main cause of melanomas, but artificial sources of UV radiation like sun lamps and tanning booths play a role too. UV radiation damages the deoxyribonucleic acid in skin cells, causing mutations in their genetic code, and this alters the cells. So again, here's your big, risk factors. So red or blonde hair, light colored eyes, fair skin with freckles, chronic sun exposure, and family history. So it doesn't mean that someone that doesn't have some of these things can't get it still. They can, but 9 times out of 10, it's going to be a person like this. And then this also talks about the use of immunosuppressive drugs, and history of dysplastic nevi also would increase your risk. Okay, going back to our case study. So we're assessing this lady's mole, and note that it's 5 by 8 in diameter, shaped like a jagged pebble. She describes the changes she has noticed. The color has changed from brown to black, and it's increased in size and feels bumpy. So what other questions would you ask her regarding her mole? So you would want to know what it looked like originally, right? So you want to see, hey, what was the original size, shape, and color of the mole? Because that's kind of important to see, the change. When did she notice it beginning to change? Does she have any pain at the site when you palpate it? And then does she have any other moles of concern? Because a lot of times people have multiple areas. Okay, so remember back a few slides ago, we talked about this ABCDE rule. So this is typical with all skin issues. So we always look for asymmetry. So does it look like it has irregular pattern or growth? The border irregularity, has that changed? The color, the diameter, and the evolving in appearance. So that's kind of what all of those stand for. So here's some examples of malignant melanoma. So you can see, look at A, that looks kind of distinct, right? You see this really dark area up top, and then you have a color change, kind of next to it. All of these look kind of weird. They look different, but they're all malignant melanoma. So look at B. That almost looks like you have like little growths all in one area. It's weird. So it's not always going to look the same. You kind of have to get that in your head that it's going to look a little different sometimes. Okay, so handheld screening devices, they have something called a MELA-FIND. It can help healthcare providers to determine whether a lesion without the obvious ABCDE signs should be biopsied. Suspicious lesions should be biopsied using an excisional biopsy technique. The most important prognostic factor is tumor thickness at the time of diagnosis. Two methods to determine thickness are currently being used. They have the Bristow measurement that indicates the depth of the tumor in millimeters, and then they have the Clark level that indicates the depth of invasion of the tumor. So the Breslow measurement of tumor thickness, that's what this A is here. This says 0.08 millimeters. It's superficial and it's a spreading melanoma, which would have a good prognosis. This one down here in B is a thick nodular melanoma with lymph node involvement and a poor prognosis. Boy, that looks crazy. Okay, going back to this lady in the case study. So an incisional biopsy was done on this person's mole, and they diagnosed malignant melanoma. So what factors will determine the next steps in treatment? And then this says, what are the possible treatment options? So what would you do for someone who has this? So treatment is going to depend on the site of the original tumor and the stage of the cancer, because you always have to stage it, and the patient's age and general health. Initial treatment of malignant melanoma is wide surgical incision, so they're going to surgically remove it, and it may require a skin graft to close. Melanoma that has spread to the lymph nodes or nearby sites usually requires additional therapy, like chemotherapy, immunotherapy, targeted therapy, or radiation therapy. So if you catch it quickly and you're in some of the early stages of cancer, then your chances are usually pretty good that you'll recover and be okay. But if you catch it late and you already have lymph node involvement, usually you don't do as well. Okay, in staging of the melanoma, they have stage 0 through 4. So it's based on the size of the tumor, how thick it is, nodular involvement, and presence of metastasis. In stage 0, the melanoma is confined to one place in the epidermis. Melanoma is nearly 100% curable by excision if it's diagnosed by stage 0. The 5-year survival rate depends on sentinel node biopsy results, which indicate if metastasis has occurred. The presence of metastasis in the sentinel lymph nodes is the most important prognostic factor for reoccurrence. So if you do have metastasis, chances are it's probably going to reoccur somewhere else at another time. Okay, immunotherapy, that's an option for treatment. So cytokines include interferon and interleukin. So they have these other meds here that they talk about that would be considered immunotherapy, and talks about kind of what they do here. So sometimes that's a good option for people. It helps you boost your immune response against these specific cancer cells. They also talk about targeted therapy. Targeted therapy is drugs that attack the specific protein directly. So a lot of times, say you're getting chemo doesn't necessarily go right for the cancer cell. It might go for all of your other cells too. So it's going to cause you more problems than what you're really trying to deal with. Targeted therapy goes right for the mechanism of problem. So if you have this one cancer cell that you're trying to get at, it goes right for that, and it doesn't affect everything else around it, which is kind of nice. Okay, going back to the case study. So she has her mole excised and her axillary lymph nodes on the right side are dissected to assess for metastasis. Lymph nodes are negative for cancer cells, thank God. So how would you expect this mole to be classified in terms of staging her tumor? Stage 0? Would you expect that she requires additional treatment after excision? This is not required for stage 0 tumors in which the entire margin of the mole is excised and the lymph nodes are negative. So she asked if this means that her cancer is gone. So how would you respond? So the surgeon discusses the final outcome of the surgery and the biopsy results. After the information is conveyed, you will be able to reinforce that the cancer has been removed and she will need to be watchful and report any new changes in this or other areas. So in other words, this girl, they found this melanoma, they found it quick because they said it was a stage 0. It did, they were worried that she had lymph node involvement, so they took some of her lymph nodes to do testing to see if she did. She did not. So as a result, this means that that's all they needed to do. They just needed to take that lymph node out. She doesn't need to do chemo. She doesn't need to do radiation or anything else. So now she just needs to be really watchful that nothing else pops up in the future. Does that make sense? Yes, no?
Yeah, it does. It makes sense.
Okay. Let's see. So the surgical procedure that was likely used to excise her mole is something called a Mohs procedure, which would be used to excise the tumor in layers. It examines each layer to determine whether the margin and the depth of the tumor have been reached. And then this is saying, have your students role play. We don't need to do that though. What are some suggestions that you can make to assist her in adapting and camouflaging her scar? So they're saying, hey, wear short sleeve shirts rather than sleeveless to conceal the scar, because this is on her shoulder. So that would be something. Maybe she could add scarves or shawls to, dress up her whatever she wears to try and keep it covered. Try using makeup to conceal the scar when wearing sleeveless shirts, bathing suits, etc. Which I don't know how well that would work though. If you're putting makeup on your shoulder and you go, swimming or something, it's going to come off, right?
Yeah.
Okay, which patient is at highest risk for skin cancer? So they're saying it's C. So why do you think that is?
The tannin boost.
Yeah, the tanning.
The UV light from it.
Yeah, the tanning booth's the big thing there, definitely. Okay, so that's like the first part of that was all skin cancer stuff, and now the rest of this gets into like skin infections and stuff. So this talks about a bunch of different kinds. So we got bacterial, viral, and fungal, and even some bites. So it's kind of crazy, but bacterial infections occur when the balance between the host and microorganisms is altered. So a primary skin infection occurs after a break in the skin, and a secondary infection occurs to already damaged skin as a result of a systemic disease. So some of the things that you might see a lot of with bacterial infections would be Staph aureus and group A hemolytic streptococci. So those are ones that are kind of responsible for a lot of those types of skin infections. Streptococci cause impetigo and some of these other things, cellulitis, which we see all the time, and lymphangitis. Staph aureus causes folliculitis, cellulitis, and furuncles. So what do you think folliculitis is? Have you ever heard of that before?
No.
So what's a follicle? Have you guys heard that term before? If we talk about a hair follicle, what is that? So if you have folliculitis, you have an infected hair follicle. That's all it is. So you know how we have like hair on our arms and our legs and stuff in all these different areas. So you could have this happen, you know, pretty much anywhere. So you have this infected hair follicle and it gets pretty bad. Okay, so viral infections of the skin are difficult to treat because with the virus, you can't just go ahead and give an antibiotic because it's not going to help. Herpes simplex, herpes zoster, and warts are the most common viral infections affecting the skin. The possibilities of exposure to infestation or harboring insects or worms or insect bites are numerous. Allergy to the venom and reaction to eggs, feces, or body parts of the invading organism can cause clinical manifestations. That just creeps me out thinking about that. So here is an example of someone who has scabies. So look at this person's hand. They have all of these different areas affected by the scabies. And then with fungal infections, we typically see something like candidus. So this person unfortunately has it right between their fingers here, which looks really painful. Most fungal infections are relatively harmless in healthy adults, but they can be embarrassing and distressing to the patient. Skin, hair, and nails can become infected with fungi, including candidus and tinea, I can't say it, unguium. So yeah, you know, anyone who has a fungal infection, sometimes you can get, like, I don't know if you've ever looked at people's toenails, but sometimes people can get a fungal infection of their toenails where their toenail will change color and it looks like really not quite right. So you have to get treated for that to get rid of that. And then a lot of people get the yeast infections and stuff. That's all fungal. So sometimes it gets very difficult to treat that. Then we've got these allergic dermatologic problems. So these are associated with allergies and hypersensitivity reactions. So a careful family history and discussion of exposure to possible offending agents can provide valuable data. Patch testing is used to help to determine possible causative agents. The extreme pruritus and its potential for chronicity make it a frustrating problem for you and the patient, especially if its offending agent can't be identified. And I know all about this because I constantly have issues with stuff like that. I have these areas on my eyelids right now that are like these patches of something that they get really dry and itchy. And so if I'm rubbing my eyes, it makes my eyes swell up really big and they get all red and stuff. So I have some kind of stuff that I'm putting on now that the dermatologist just gave me to try and help with that. But it's difficult because you can't really pinpoint what caused it, you know? Usually sometimes it's something that you were exposed to, like they always say, oh, did you change laundry detergents? Did you change, you know, deodorant or whatever, you know? But usually it's, I don't know, we don't really change things very often around here, so it's typically something else for me. I don't know what it is. Okay, benign dermatologic problems. So this would be stuff like acne, psoriasis, or seborrheic keratosis. So a lot of people suffer from acne. It's an inflammatory disorder of the sebaceous glands causing non-inflammatory lesions. Usually you get blackheads and stuff like that with it. And then psoriasis is an autoimmune disease. Men and women develop psoriasis at equal rates. It occurs in all racial groups, but at varying rates. It usually develops in persons between 15 and 35, and 1/3 of people with psoriasis have at least one relative with the disease. Lesions are distinct and appear red, scaly papules, and merge to form plaques. The affected area is normally rounded with adherent silver scales that bleed easily when removed. I had a girl in one of my classes years ago who had this, and she had it bad. She had it everywhere. So there's medication and stuff that you can take for this, but it takes a while for it to work and to help with this. There's a lot of weird types of interventions they do to help with psoriasis. I don't know if you guys remember reading about that at all. Do you guys know anyone that has psoriasis? So it has like a really distinct look to it, so you should never forget it when you do see it on someone.
Kim
Okay.
Kardashian had it?
What's that?
Kim Kardashian have it?
Oh, she
Oh, yeah,
could. She could.
Yeah,
that's
she did. I know
happening.
she mentioned. She said she did.
Okay.
It was a video.
Yeah, I understand.
All right, seborrheic keratosis. So this produces a irregularly round or oval papule or plaque, which is well defined in shape with the appearance of being stuck on. It's benign, familial, and exact etiology is not known. So my grandfather used to have a lot of this. Like he'd have these weird spots on his skin. So this, they're saying that it's so big and everything that it almost is like someone stuck it on you and it stayed there, you know? Like you can't really understand like why someone has this or where it came from. Okay, so this starts talking about some of the ways that you can treat some of these skin issues. So diagnostic and surgical therapy techniques include skin scraping, you know, where they would scrape some of that off. They can do electrodesiccation, electrocoagulation, curettage, punch biopsy, which is what I had on my nose, cryosurgery, which would be freezing that area off, like they would do with a wart or something, and excision, where they would actually cut it out. Tissue biopsy is the definitive test for diagnosing a number of skin lesions, particularly cancers of the skin. Ultraviolet light of different wavelengths may be used to treat many dermatological conditions. So psoriasis is one that they do that for. They actually do photodynamic therapy to treat that. Other things, radiation therapy to treat, you know, basal cell carcinoma or squamous cell carcinoma and malignant melanoma. One advantage of radiation therapy is minimal damage to surrounding tissue, because when they do radiation, they could do it targeted to one area. However, it does usually requires multiple visits to the radiology department. So typically you have to go a lot of times to get a lot of treatments. Lasers sometimes are used for different skin problems. And then of course, drug therapy. They have antibiotics that could be topical that you could use. Corticosteroids, sometimes they're used, you know, for short term to kind of, you know, fix a skin issue. Oral antihistamines, there's all kinds of stuff they can use here. And then this just goes into it some more here. I'm not gonna go through all that, you guys can read that. All right, and then with nursing management, they say dermatologic conditions are not common reasons for hospitalization, although it may not be the primary reason that they're in the hospital, they still might have it while they're there. So things like wet compresses are commonly used when there's oozing from the skin and to debride superficial wounds. Wet compresses also provide comfort and treatment of conditions like poison ivy, insect bites, and skin infections. Simple tap water or bottled water may be used, depending on the problem. Sometimes you might see that they add an antibacterial solution in with it too. Baths are an appropriate intervention when large areas of the body need treatment. They can be relaxing and will help decrease the itching. Topical medications, if you have that, you would put a thin layer of the ointment on. It should be applied to skin that's clean and spread it evenly in a downward motion in the direction of the hair growth. An alternative method is for you to apply the medication directly onto a dressing. And then with itching, so pruritus. This can be caused by dry skin, almost any physical or chemical stimulus to the skin, or some kind of skin disorder that you have. So to kind of, you know, treat this, a cool environment may cause vasoconstriction and decrease the itching. So if you're in a cool area, that might help. Hydration, wet compresses and moisturizers can be helpful. Topically applied corticosteroids, menthol, camphor, or phenol can be used to numb the itch receptors. So those are some things that you could possibly do. All right, and then we want to prevent the spread of anything going on with the skin too. So we always need to do really careful hand washing and dispose of soiled dressings and stuff so we don't spread anything. Open skin lesions are susceptible to invasion by other things like viruses and bacteria and fungus. So you have to be really good about your hygiene, what you do. If you're messing with someone's nails, trim their nails short to minimize trauma from scratching. And then sometimes you're in the position to teach people about some of the surgical procedures they might be having done, like skin biopsies or cryosurgery or something. So whatever information that you could give them would be helpful. A sutured wound may be covered with a variety of dressings. If necessary, a topical antibiotic is applied and the wound either is covered with a dry dressing or left open to air. Intermittent application of cold or ice packs over the surgical dressing may reduce edema, so that's always a good thing. Okay, this talks about chronic dermatologic problems. So emotional stress can occur for people who suffer from chronic skin problems like psoriasis and dermatitis or acne. The sequela of chronic skin problems could result in social and employment problems with financial implications, poor self-image, problems with sexuality, and increasing progressive frustration. Help the patient comply with the prescribed regimen. Dermatology patient support groups are a good thing to do too. Sometimes that will help people. And then a lot of times you can kind of camouflage some of these lesions skillfully with cosmetics and stuff. So there's certain things that you could do to kind of make it look a little bit better. Okay, the nurse is caring for a patient with anxiety related to a skin condition. Which intervention would be most appropriate at this time for the nurse to add to this patient's plan of care? So this is saying A. So you want to encourage the patient to express their feelings of anxiety. Figure out what is making them anxious about their skin condition. And I think we're almost done here. We have just a couple more slides. Okay, cosmetic procedures. Topical procedures include like when they give you that Retin A, chemical peels, microdermabrasion. These agents improve the appearance of photo-damaged and wrinkled skin, acne scarring, actinic or seborrheic keratosis. Injections include Botox, and then there's some other ones they list here. Elective surgeries would be things like laser removal to treat congenital and acquired vascular lesions like cherry angiomas or spider leg veins, port wine stains, those types of things. A facelift is the lifting and repositioning of the lower 2/3 of the face and neck to improve appearance. Liposuction is a technique for removing subcutaneous fat to improve facial and body contours. And it can be successful in removing areas of fat from virtually any body area that is resistant to other techniques. Okay, so with preoperative management for anyone that does a cosmetic procedure, you want to explain things to them. So explain the oozing, the crusting stage of abrasive procedure so they can plan time off of work if necessary. You need to kind of tell them the time frame of healing, since the wound healing may not be complete for almost a year. The patient should not anticipate complete results immediately. With post-op, most cosmetic procedures are not extremely painful. Usually mild analgesics are good enough to keep them comfortable. If the surgery involved an alteration in the skin circulation, like a facelift, carefully monitor for adequate circulation. Warm pink skin that blanches on pressure indicates adequate circulation. All right, and then this talks about skin grafts a little bit here. There's probably going to be a time where you take care of a patient who has a skin graft. So the skin grafts can be necessary to protect underlying structures or to reconstruct areas for cosmetic or functional purposes. They can be used to facilitate rapid closure and minimize complications. Skin grafting can be necessary to close the defect of large wounds, surgically created wounds, trauma, and chronic wounds, resulting in extensive tissue destruction, making healing by primary intention impossible. Free grafts are classified according to the method of providing a blood supply to the grafted skin. One method is to transfer the graft to the recipient site from the donor site. The autograft, which would be from the patient's own body, or isograph from an identical twin, revascularizes and becomes fixed to the new site. With reconstructive microsurgery, an operating microscope is used and circulation is established immediately in the graft by anastomosis of the blood vessels from the skin flap to the vessels in the recipient site. Skin flaps involve moving a section of skin and subcutaneous tissue from one part of the body to another without terminating the vascular attachment. Skin flaps are used to cover wounds with poor vascular bed, providing padding when needed, and to cover wounds over cartilage and bone. A lot of times when you would do like someone had an amputation, a lot of times they'll do a flap over the end of that. So that covers the area that they cut off. Let me see here. Okay, a pressure dressing is applied to the face and neck of a patient following a facelift surgery. The patient tells the nurse that the dressing feels restrictive and asks if it can be loosened, which response by the nurse is most appropriate. So it's going to be A. The dressing is used to prevent bleeding into the skin. So in other words, no, they can't take it off. They need to, help, prevent bleeding at the time for that. So again, out of this stuff on your test, you probably won't have a ton out of this. There's a little bit, but not a lot. And Vera, I know you asked me if you're going to get a tips for the test. You will. I just didn't have a chance to do it yet. So I'll try and do it later today and maybe send it out to you later this afternoon or something.
Okay, thank you.
Okay, so I was trying to think of something different for us to do in class today. So I was thinking about this bingo thing. I don't know if it's going to work right, but we'll try it. So I sent each one of you guys a bingo card, and they should all be slightly different. Everyone has like the same things on their card, but in different places. So I don't know if you were able to print it out. If you were, you can actually like get coins or whatever and put it on, your bingo card like you normally would. Everyone's familiar with how to play bingo, right? Or not?
Yeah.
So obviously, like here's one of them here. So obviously you could get a bingo this way, you could get one this way, you could get one, across. Any of those ways would be fine. So if you get a bingo, after we go over some of this, then just yell out bingo so I know you have it, and then we'll kind of go from there. All right, you guys ready?
Yeah.
Okay, so I get this isn't quite your normal bingo. I get it. I was just trying to do something different, so hopefully it works out all right. Okay, increased ocular pressure. What am I referring to? What eye condition that we talked about in our reading would have increased ocular pressure?
Is it glaucoma?
Glaucoma, you're correct. So look on your
Ding, 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 ding.
Yay. Okay, look on your card, and wherever you see increased intraocular pressure, you're going to put a little spot there, a little coin or whatever, to show that you got that. Okay, excessive exposure to the sun can cause this eye problem. Think about the eye things that you read about, the eye issues. What can cause, excessive exposure to the sun? What does that?
Wait, can you word it in a different way because I'm just slightly confused.
Okay, so there's certain eye conditions that we talked about. Like, think about it for a minute. We talked about glaucoma. We talked about. Say that again.
Is that cataracts?
Yes, cataracts. That's the correct answer. So it's just something that causes cataracts, basically. You know, being in the sun too much, not protecting your eyes with sunglasses is kind of what I'm getting at.
Okay. Okay.
So find that on your board, put your little mark there. Okay, a type of hearing loss that can be caused by impacted cerumen.
Conductive hearing loss.
Try again. What's the other one? What's the other type of hearing loss? It's sensorineural. So that one's sensorineural. Okay, so our next one, reddened, thickened skin with silvery white scales. And we just talked about it in this PowerPoint. What skin condition has that?
You said with silver something, right?
Yeah, so it's reddened, thickened skin with silvery white scales.
Psoriasis?
Psoriasis, you're right. Yeah, psoriasis has a really distinct look to it when people have it. You'll never forget it when you see it. Okay, so remember the other day we talked about all of the sexually transmitted infections. So which one had a canker that it started out with that can open up and cause spread to others?
Would it be herpes?
No, that's a good guess, but no. This has 3 stages to it. Aman, what did you have?
Is this syphilis?
It's syphilis. So syphilis has like 3 stages to the disease, and you get a canker. It's a specific like skin lesion type thing that will open up. You know, it'll once it's open and like oozing and stuff, you can spread it to other people. So like you can have it on your genitals, you could have it in other places too. But that canker, that's specific to syphilis. You guys finding these spots on your board?
Yeah, thank you.
Okay. All right, the next one. Did you remember the sexually transmitted infection that's caused by a parasite?
Is it trichomonas?
Yes, trichomonas, definitely. Okay, so someone tell me an intervention for insomnia.
Like or staying or sleeping or resting in a dark space or dark room
Okay, so making your room nice and dark.
and
Okay.
quiet.
Yep, that's a good one. Anyone have any other thoughts? Some of the other things you could think of would be don't go to bed until you're sleepy. So sometimes you'll see older adults who have insomnia. They'll go to bed and they'll just lay there and lay there and lay there because they're not really sleepy yet, but they went to bed anyway. So don't go to bed until you're actually sleepy. And then have some type of bedtime routine that you do. So, maybe you have a warm glass of milk before you go to bed, or, whatever you do, your normal routine. And then they say try to avoid eating a really large meal before bed. And then also in the book, it talks about don't read or watch TV before you go to bed, which a ton of people do.
I never knew that. I thought that is supposed to actually stimulate you to.
I know. I always thought that too, but so I guess not. All right, so I think it was last week, we talked a little bit about PCA pumps. What did I say was something that people do a lot of that they shouldn't do with PCA pumps? Like,
Is that like they keep pressing for more? Like let's say they were told to use it like every 10 minutes, but like every minute they keep would that be it?
No, that's not quite what I'm getting at.
Okay.
What do family members do with PCA pumps that they shouldn't be doing?
Oh, they'll be pressing it for the patient.
Yeah, they're pressing the button for their family member. So that's misuse of the PCA pump. And remember, we said by them pressing the button, it could cause this person to go in respiratory distress or start to quit breathing, basically, if they keep doing that.
Yeah.
Okay. All right. Someone tell me what visceral pain is. You can look it up real quick if you want to, if you don't know.
So wait, isn't visceral like organs? So wouldn't that be like organ pain?
Yes, exactly. Okay, which type of pain medicine is contraindicated in someone with renal insufficiency? So in other words, when you're looking at pain medicine and you're seeing some things that might happen as a result of it, which person should not get this type of pain medicine? Like if I have, kidney disease or something like that, I shouldn't be taking this.
You shouldn't be taking Tylenol if you have kidney disease.
I'm sorry, I'm having a hard time understanding you, Lisa.
Oh, sorry. I said you shouldn't be taking Tylenol if you have any kidney disease.
Okay. Yeah, so NSAIDs basically is what I'm trying to get at.
Oh, okay.
Okay, the next one's kind of weird, and I don't know, hopefully you guys read this in your book because I don't think I ever would have got this. Okay, so in the part of the content that you guys had about palliative care and like end of life stuff, they should have talked a little bit about signs and symptoms of dying. And this one is asking for one last sign and symptom of dying. So meaning that you see all of those other things first, and this would be one of the last things that you might see happen.
Is it Chinese breathing?
The breathing?
Not about breathing.
Oh, the last one. Is it the hearing loss?
It's the hearing, yes.
Ding, ding, ding.
Which I never would have got that,
Because that question is not very clear. They should have
Yeah.
sensory.
It's weird.
Wait, what is it that they hear though?
That's the last sensory sign that goes away right before they die.
Oh, okay, got it. Okay.
All right, and then doxycycline is a medication that sometimes we'll give for certain STIs, right? So what's an important nursing consideration to know with doxycycline? You know, like when you're filling out a med card and it'll say important nursing considerations like, oh, maybe I need to consider that, you know,
If the patient is allergic to tetracycline, they can't take they can't take the doxycycline either.
that's not what I'm getting at, but that's a good thought though. You know how certain medications have like,
Let me take a guess.
go ahead.
Is it when they get like a super infection, like the Mornelia infection?
No.
Like, okay.
I think like when they're taking it, they need to avoid going into the sun.
That's it. That's what I'm looking for. Good job, Vera. And why is that? What happens when they go in the sun?
My question is this, are you talking about a skin condition using artificial photography? What question is this?
So on your board it says important nursing consideration with doxycycline.
Oh, okay, I just saw it. Okay, thank you.
See it?
Yeah.
So what would happen to you if you did go into the sun when you're taking that?
Don't they get skin burns or something like that?
Yeah. Okay, the next one. When are you contagious with genital herpes?
That's a good
During the
question.
outbreak, when you have the open doors during the outbreak.
So it's always. You're always contagious. So some people think that when things start to go away that they're not contagious anymore, but you are always contagious. So it's before, during, and after blisters are present. Okay, let me see what's next. All right, what's the best way to evaluate a patient's learning?
Teach back, like return demonstration.
Yeah.
Bingo.
Oh, you got a bingo?
Yeah.
All right.
Bingo.
Two people have bingo? Nice. All right. We'll keep going because I have a few more to tell you, so we'll see if anyone else gets it. If we were actually in class, I would give you something for getting a bingo, but I can't, from afar here, so I apologize. But good job, guys. Okay, what should a nurse do when using an interpreter? What are some things to consider when you use an interpreter?
You maintain eye contact with the patient.
Yes, definitely, because a lot of people will just talk to the interpreter and totally forget about the patient, for sure. Anything else? You always have to remember to not use any kind of slang when you're trying to tell the interpreter what you're trying to say, because sometimes we tend to use a lot of slang words in the United States, and so the interpreter might not know how to say that in the language they're trying to interpret, So that's another thing. What is myopia?
Nearsightedness,
Okay.
like when you can see close.
So you can see objects that are close, but you have a
But you
hard time
can't-
seeing ones that are far away,
Yeah.
right? Okay. What's a finding to indicate sensory neural hearing loss when you do a Weber test? So think back to when you did your Intro to Clinical Nursing class, when we had our FUNS book, the ATI FUNS. Do you remember learning about the Weber test? So you know how you had those little, what do you call those things? The things that you hit and they make a noise and you put it by the ear. What the heck are those called? like tuning forks. What do you remember about the Weber test?
I think if they can't hear it, the sound anymore, it means like they have a hearing loss or something.
Isn't it like air condition versus bone condition or
Yeah, yes, you're kind of right. So there's when you do the Weber test and you use that tuning fork, when you put the tuning fork by their ear, it's going to tell you if they have a certain type of hearing loss, if they hear it in their good ear or their bad ear, right? So if you hear the sound in your good ear, that means that you have sensory neural hearing loss. So like if you put it by their bad ear, they wouldn't be able to hear it. They'd only hear it in their good ear. So I will tell you, there's a couple of weird things on this test like that. So go back and review the Weber test a little bit to make sure you get that part, because there is a question about that. And then there's something about cranial nerves too. So make sure you look at that stuff again and make sure you feel good about that. Okay, where did I leave off? Okay, how about important skin mold changes to get checked out? We just kind of talked about that in the PowerPoint.
Color, size, whether it's bleeding or not, the discolorations,
Yeah,
all of those fun stuff.
yeah, so it would be an increase in size, irregular edges, change in color, itchiness or skin breakdown associated with it. Okay, what is a skin condition that we talked about that uses artificial phototherapy as an intervention? I just mentioned it in the PowerPoint. So it means that you use light therapy to try and fix it. This is psoriasis. So psoriasis has a bunch of different things that they can do for it, but that's one of the interventions they can do is phototherapy. Excuse me.
you can go.
Oh, you got one? Good. Good job. All right, we're almost done. We got, let's see, 1, 2, 3. I got 6 more things to read, so we'll just keep going and make sure we get them all. Okay, the next one is type of person more at risk for melanoma. What puts you more at risk for that? Remember in the PowerPoint there were
If you
specific
are
characteristics.
white,
Okay.
age 55 and above.
Okay. What else?
Blonde hair with blue eyes.
Usually they have really light skin. A lot of times they have freckles, that type of stuff, right? Those people are definitely more at risk. And then name someone more at risk for a health disparity.
Low educational status, social economic status as well.
Okay.
Low health literacy.
Okay.
Race, culture, all of them.
Transportation, health accessibility, all of those.
Okay.
Economic status.
Economic status. And then also sexual orientation. You know, sometimes
Oh,
they have
yeah.
health disparities, right?
LBG.
Yeah, yeah. Okay, name one stress management technique that you could teach a patient.
Imagery therapy, exercise,
Okay.
Meditation.
Okay. There's, 3 million things you could say here, right?
Yeah.
So, guided imagery, you could say go
Yoga.
yoga. Yeah, yoga's a good one.
Meditation.
Tai Chi. There's all
Medi-
kinds of things you could do. And medication, yes, you could do that too. But yeah, there's all kinds of stuff we could say there. All right, what are some risk factors for sleep apnea?
Obesity, hypertension, cardiovascular disorders.
Okay.
Um, you end up growing older than you look. Physical.
So risk factors for sleep apnea would be being overweight, like you said. These people a lot of time have a really thick neck. Usually it's going to be someone over age 40. And a lot of times, like just their body habitus, like they have large tonsils back there, and sometimes they have a really large tongue. So they're typically more at risk because all of those things would cause, their airway to kind of close off, so they couldn't breathe as well.
Doesn't sex also play a part? Isn't it like
Kind of, but men and women both get it. So,
right?
all right, name one example of elder abuse.
Extortation, money.
Okay.
Neglect.
Sorry.
Did someone say neglect?
Yes, neglect.
Okay.
If the elder refuses care, and for example, the elder refuses medicine, the nurse puts the medicine in aftershelf and feeds it to the elder after they refuse it.
Physical restraints.
Okay. Yeah, there's a ton of things you could say here. Just think of all the different types of abuse in general, and any of those would work here, right? Okay, and last one, when is a good time to teach?
I think whenever the patient tells you it's best for them to learn.
Okay.
Yeah.
Because the thing is, as a nurse, you really never have a good time,
Right.
but you have
When
to
you're
be you have to be doing it ongoing all of the time. But there's certain times where it's just not appropriate to try and get someone to learn something that you're trying to say. So what would be times that aren't appropriate to teach?
When they're sleeping or when they're in pain.
Yes. So if someone's in extreme pain, they're not going to listen to you, right?
Mm-hmm.
Or if, they're falling asleep because they just had dinner or something, it's not a good time because they're not going to have your full attention.
Right.
If they're uncomfortable in some way, like they're in a room that's really hot or doesn't have good lighting, or they can't hear you, you have to think of all of those types of things with teaching to make sure that they're going to be receptive to you. And then I don't have this one on here, but so if you're teaching someone, like say it's an older adult, what kinds of ways do they prefer to learn? What kinds of things would be good to use with them? Do they like handouts?
Not really. We'll like be implementing like hands-on stuff where they like get to participate, or using like the past experiences and stuff like that.
Well, you're thinking adults in general. Adults in general, yes, but older adults, they tend to like picture type handouts, and like if you were doing a presentation, maybe you do a PowerPoint or something, because it's just they need to see it, to refer back, to something that you said.
Right.
Okay. All right, so that was my attempt at doing a game. Sorry, I know it didn't turn out as good as I wanted it to, but it's hard to find good stuff to do online. I was looking on this one site, and they have nursing games, but some of them are just, oh. This one, it's one where it talked about like skin disorders, and I thought, oh, okay, maybe we could do that. But then when I did it, it's like it wants you to spell everything out, and you have like a timer, and it's just crazy. So if you don't spell it right, you don't get it, and I don't know. So
But to be honest, the bingo wasn't bad. I think that we still learned a lot.
okay, I hope so. All right, one more thing I want to do, and then I'll let you guys get off here. So let me see if I can find it. So I have other books on my account, from other classes that I teach. And this one is Through the Point, and it's a med-surg book. But they have some other things to do in here. So let me see if I can pull this up. There's an activity I thought maybe might be helpful if we can do it. Can you see that?
Yeah, we can see it.
Okay. So in here, this is this book here. Okay. So this is what I use with my other adult class that I teach. So they have these student resources, and this is like practice and learn activities, which I kind of like some of these. Not all of them are that great, but some of them are pretty good. So I was looking through here, and I thought, well, what are some of the topics that we talked about? What might be helpful? So let's try this eye and vision disorder one and see if this does anything for us. So basically it'll say, hey, here are your learning objectives. So this is going to focus a lot on glaucoma. So you know how there's chronic open angle and angle closure glaucoma. So there's a difference between those. So we're going to get into that. Okay, so we have this lady, Josephine Davis. She's a 78-year-old woman who lives alone with her dog, McBeezer. That's funny. In a 2-bedroom home that is part of a retirement community. Except for her hypertension, which she manages with lisinopril, osteoporosis is managed by Aldronate, which is your Fosamax, and myopia that is corrected with prescription glasses. Mrs. Davis considers herself in good health. Recently, Mrs. Davis has noticed changes in her vision. She makes an appointment with the nurse at the Retirement Community Health Center. At the appointment, Mrs. Davis says to the nurse, I think I need new glasses. My vision is blurred. It's not clear as it used to be with my glasses on. When I drive at night, I see rings around lights and things sneak up on me from the sides. I also am having trouble seeing when I read. I even changed the light bulbs to make it brighter, but it didn't seem to help much. The nurse conducts an eye assessment and notes the following. So she has Perla with slight delay in response to light. Her right eye is slower to respond than the left. With the Snellen chart, Mrs. Davis reports blurred letters at all acuity levels. The peripheral visual field, she has decreased visual field bilaterally, so she doesn't see real good out of both parts of her outside portions of her eyes. With inspection, she has slightly reddened sclera and clear lens. No cloudiness is noted. So you know, because there's no cloudiness on that lens, you know it's not cataracts then. Okay, which of the following directions will the nurse give Mrs. Davis when assessing peripheral vision?
D.
Is it D?
Oh, which one do you guys want me to choose?
E.
B?
Mhm.
It's D.
Yeah.
So you're going to look straight ahead and tell me when you see my fingers. So when you assess peripheral vision fields, you identify the moving objects such as the nurse's finger when it's first seen. Okay. Okay, this is true or false. Decide whether the following statement constitutes additional information that the nurse should include in baseline assessment of her visual status. Have you had any pain or discomfort in your eyes recently?
Yes.
Okay. Definitely. Decide whether the following statement constitutes additional information that you should include. Have you noticed any drainage from your eyes?
Yes.
Okay. What were the results of your last eye exam? Would that be something you would ask?
No, I'll say yes. Not too sure, but I'll say yes.
You think yes?
Yeah, I think yes, but I don't know. Yay.
Okay. Good so far. All right. And then this is saying, what dietary restrictions do you have? Does that have anything to do with anything?
Not really. No.
Is everyone agreeing or no? No one else is saying anything. I'll say false, I guess.
Yeah, false. Yay! Woo!
Good so far. Okay, and then this is saying, what medications are you currently taking?
True.
Right? Because you never know. There could be something that could be causing that, right?
Right.
All right. And then how many hours do you sleep each night?
True. Oh, no.
That's okay. So they're saying, you know, with some of the stuff that you see in this situation, that doesn't necessarily mean anything if she's not sleeping a lot. Okay. And then have you experienced any recent injury to your eyes?
True.
True.
Yes.
Okay. And then, okay, so now we have the rest of this case study. So based on her assessment findings, the nurse suspects that Mrs. Davis has glaucoma and suggests that Mrs. Davis make an appointment with the ophthalmologist. Mrs. Davis follows the nurse's suggestion and makes an appointment to have her eyes examined. At the examination, the ophthalmologist does several assessments, including tonometry, peripheral visual field mapping, I can't even say half this, gonoscopy, and a direct ophthalmoscopic examination. The results of the examination were as follows. With the tonometry, it said increased intraocular pressure, so she definitely has that, so it was 28. Peripheral field mapping, she had several scotomas present with the peripheral field smaller than normal. And then with the other thing, it said she had pale optic nerve and cupping of the optic blood vessels bilaterally. So the ophthalmologist tells Mrs. Davis that she has chronic open-angle glaucoma. The ophthalmologist prescribes some eye drops. So she's got pilocarpine 4% gel, half a strip to each eye at bedtime, and then she's got timolol 0.5%, 1 drop to each eye twice a day. The ophthalmologist tells Mrs. Davis to make a return appointment for 1 month to decrease her driving and to contact the office if she experiences sudden severe pain in either eye accompanied by headache and nausea and vomiting. Okay, this one's probably going to be tough. You guys probably won't know this, so we'll just guess at this. These are those different types of tests, and you're supposed to like match with what they are. So see if you can help me figure this out. So which one looks at the visualization of the internal structures of the eye? I think it might be this one. Which about this gonoscopy? That was the first thing, and I think that's the one that talked about the increased interocular pressure. And the perimetry testing is probably this evaluation of the vision field. I don't know. Help me out, guys.
Yeah, I think the second one on the visualization part goes with the O word.
Yeah,
So
so that
yeah,
goes with this. Trying to figure out how
yes,
to do it.
but you gotta click it.
Oh yeah, that goes down
But
here.
yeah.
That was this, right? Internal structures of the eye.
Yes.
Okay.
And then the testing one, just pick
that's
the
this
one
one,
that
I
sounds like
think.
a test.
Perimetry.
Yeah, that
right?
sounds like a test or something.
Okay. And then these two I'm not sure about, so you guys tell me about those.
Put the last one with the T word.
That one?
Yeah.
Okay.
I'm just guessing because I don't know.
Yeah, that's all right. I don't know either. Oh, look at that. You're good. That's funny. Good guesser. Okay, which of the following factors increase the risk for developing glaucoma? So this is a good one for us.
A.
Age.
D. Was smoking? Yeah.
African Americans.
I don't know for sure, so you tell me.
I feel like African Americans, it just sounds like that would be more than European ancestry.
Okay, let's see if we're right. Oh, you're right with African American. So family history, African American, and age. So the cigarette smoking is what you're on.
Is the cigarette smoking with cataracts?
Probably.
It's not correct, yeah.
Okay, so this one, here are more factors that may or may not increase the risk for developing glaucoma. Can you identify which of these are risk factors for glaucoma?
A.
Hypertension.
Yeah, I would think hypertension definitely. Would you think migraine headaches too, or no?
Yeah, I don't know.
What do you guys think? Do you think migraines too, or not? I mean, someone can look it up, but by all means, look it up if you want to.
Mm-hmm. What's mydriatic drugs? What is that?
It's probably a certain type of eye drop. Anyone else have anything else you want me to hit here?
What about E?
Yeah, I think maybe.
You think you want me to show answer?
Yeah, sure.
Also, it's just history of diabetes, hypertension, migraine. So it was that, and then
Yeah.
the mydriatic drugs. So what's it say? Mydriatic drugs narrow the angle of drainage and may lead to acute angle closure glaucoma. Okay. I was wondering about that one. Okay. Listed below are a few more possible risk factors for glaucoma. Can you identify the ones that can constitute risk factors?
E.
B.
B.
A.
Yeah, A is definitely there.
What
I don't
think?
know, but I have a feeling C too.
You think C?
What do you guys think? I think so. I don't know. But maybe.
Well, here, we'll try it. Okay, so myopia, eye trauma, extended use of corticosteroids.
Oh, so C is not in. Okay.
Okay, so Mrs. Davis has several questions when she returns to see the nurse at the health center. When asked by the nurse what results of the visit with the ophthalmologist were, she replies, "My doctor says that I have chronic open-angle glaucoma." What is glaucoma? Isn't that sad? She doesn't know and she has it. Is there more than one kind? Is glaucoma like cataracts? Will surgery correct it? My eye doctor said that my eye pressure was high. Will my blood pressure medication help take care of that? I have 2 eyeball medications now. Or wait, I didn't say that right. I have 2 eye medications now. My doctor told me to take the medications as directed, but I don't understand the directions. How long do I have to take these medications before I'm cured? The eye doctor said I should quit driving and call the office if I have severe pain in or around my eyes. What does that mean? Gee whiz, the eye doctor should have explained all of that. All right, so when she says, what is glaucoma, what would you say to that?
Isn't it just like a buildup of pressure?
Yeah, why do you get it though?
I know it's like correlated with age sometimes.
So you know how, I don't know the exact wording for some of these things, but you know how in your eye in the corner right here, there's like a duct. What is that? Is it the lacrimal duct?
Yeah.
So sometimes it's because this duct doesn't drain right. Like there's something wrong with that duct. So that could be part of it. Like it's not letting things drain, so you build up with all of this extra pressure in there. So that could be something that causes it. And there's probably a couple other reasons, but a lot of times it's that duct. So if a patient said this, what is glaucoma? How would you describe it to a patient?
When too much pressure inside your eye causes damage to your vision? I don't know.
Okay, so it's a chronic long-term condition that can't be corrected with medications or surgery. Symptoms can be controlled by use of drops, basically. Surgery such as a trabecoplasty can also control the progression of symptoms. The intraocular pressure in the eye is increased due to a combination of factors. So increased production of aqueous humor, so that fluid in your eyes, you have too much production of it. Or a blockage of that drainage mechanism that I was just telling you about. So it could be one of those things that causes it. So this says like your hypertension and osteoporosis, it's a long-term health problem, so you just have to take your medications like you're supposed to. It's not going to be cured. So you would tell her that. Oh boy, what's this? Categorize the symptoms of glaucoma under A, if the symptom occurs in acute angle or if it's open angle. So we have to know the difference between the two. Which one's the worst one of the two? Which one did it say she had? Didn't she just have chronic open angle? Do you remember? I think she just had chronic open angle. Let's see, it says back here. Yes, she had chronic open angle. So Remember, her doctor told her that if she started to get all this eye pain or nausea and vomiting and stuff like that, that's a problem. So that would mean that it would be acute, right? So the acute one is the worst one of the two. Okay. Oh, did I skip something? Oh, no, this doesn't want to go forward. Come on. I keep skipping things. Wait a second, hopefully it'll come back. So anyway, just remember, when you're trying to figure out the difference between the two, chronic open angle is not as bad as acute angle closure glaucoma. That's your medical emergency when they have that. I wanted to do now. I totally won't go back to that screen. Well, darn it. We'll just go from here, I guess. We'll skip that. Okay, so the nurse realizes as Mrs. Davis talks that the patient has a number of learning needs. The nurse begins to develop a teaching plan for Mrs. Davis. The nurse plans to include the following topics: chronic open angle glaucoma and its symptoms, and then she needs to tell her about the worst one, the acute angle. She needs to tell her about medication administration and then also patient safety. So in addition to teaching Mrs. Davis about how to manage her health problem, the nurse also plans to refer Mrs. Davis to the state low vision service and to the rehabilitation service for driving evaluation. So the nurse is teaching a patient how to administer eye drops. Can you note down the correct procedure for administration of eye drops? What do you do when you give someone eye drops?
Hand hygiene first.
Okay. What else?
Don't touch the tip to your eye.
Tip of the bottle.
Do you have the patient tilt their head back or anything? What do you do?
Tilt the head back and pull down the lower lid.
Where do you squirt the drop at?
The lower lid. Then you'd have them close their eye.
And do one eye at a time. So do this one.
Okay, let's see what this says. All right, so make sure you have good lighting, wash your hands, read the label on the medicine, make sure the person's in a comfortable position, hold down the lower eyelid, instill the drop into the conjunctival sac without touching the tip of the medication to the eye or the face, close the eyelid, and then they usually want you to apply gentle pressure to that inner canthus right here. For like 1 to 2 minutes, and then pat the skin with a clean tissue to absorb anything that might be running down their face or anything. And then wash your hands, and then you would do the other eye or do a second medication, a little bit later. You don't want to do them one right after the other. You need to have a little bit of time in between. Okay, the nurse is teaching the patient about the administration of eye medicines. What is the correct order for administering eye drops and eye ointments?
Wouldn't it be eye drops and then the ointment?
I would think
Yeah,
so.
I think so too, D.
Yeah, I think you're right. Yeah, because, you know, eye medicine is absorbed quickly, so typically you would do the drops first. Yeah. Okay. And then the nurse is selecting interventions for the nursing diagnosis, risk for falls related to altered sensitivity to light and glare, blurred vision, impaired nighttime vision, reduced peripheral vision, and side effects of beta blockers secondary to glaucoma. Which of the following interventions will the nurse include in the plan of care? So interventions to help prevent falls in this person.
D.
So you said D, I heard, and someone said A, right?
Yeah.
Okay.
E.
No.
E.
E. Oh, you don't want B?
Turn head to skin environment while moving.
F.
I can get rid of this. I just thought that's what you said. I didn't hear you right. F, you said?
Yeah, I think so.
Does that look good?
I don't think E is one of them. Wouldn't that be a medication thing? E.
Well, so I think this is right because look up here. Side effects of beta blockers. What can beta blockers do?
Okay. I didn't see that part. Yeah, that's right.
Right. All right, so remove scatter rugs from the floor, provide a nightlight in the hallway, change position slowly, turn the head to scan the environment. I guess that was right.
Yeah.
Okay, so this one we should have had.
I just got confused because it said while moving.
Yeah, it's kind of weird.
I think the environment before, but I guess I don't know. Okay.
Oh, I don't know if this is important for you guys, but down here at the bottom it says Mrs. Davis has scotomas, if you're wondering what the heck that is. It's a blind spot in the visual field and a loss of peripheral vision. So if you ever get a chance, like if you're on Google or something, you can Google what it looks like for someone who has glaucoma, what their vision looks like, and they'll show you a picture and it'll show certain areas that are like blurry, or like if they have spots in certain places that they can't see, it'll show you that. And so that's what that is, a scotoma. All right, and then the last thing here, just as a recap. So this says you completed the practice activities related to nursing care of a patient with glaucoma. Let's review some key concepts. So this is why I like this book, because it does this at the end of everything you do. It recaps everything. Like you could print this out and everything. It's kind of cool. So anyway, the peripheral visual field is lost in a person with glaucoma. So, and remember, to assess peripheral vision, the patient is instructed to look straight ahead. While looking straight ahead, you're going to report when movement is first seen. So while they're looking, like you might be coming up with your fingers doing something, and they're going to tell you where they first see it at. Intraocular pressure is going to be more. So again, that could happen because they either produce too much aqueous humor or because they're not draining it good enough from those ducts. So one of those two. Then that scotoma, we were just talking about those blind spots that they have. So there's certain areas of their visual field that are lost. That's what that is. And remember, glaucoma is, something that they have to live with for the rest of their life. It's not something that they can cure. So you just kind of, deal with it with your medications that you have to take. And then the bottom thing, punctal occlusion. This is a technique of applying gentle pressure with the fingers bilaterally to the inner canthus of the eyes, like right here. Pressure is applied after the installation of eye drops to prevent the premature drainage of the medication from the conjunctival sac before the medication can be absorbed. So just get in the habit of doing that when you give someone drops. You'll do exactly what you guys said, but then put or have them do it. They could put their finger right there to hold pressure there for a few minutes to make sure none of that starts to drain out. Okay, so that's that. I wish we could have done the other slides. I just couldn't get them to cooperate. All right, so that's all we're going to do for today, unless you guys had any other questions specifically about something. So remember, next week when we come in, you'll have your test first thing. So we'll get that over with. It's 60 questions. I think there's 3 math questions on it. And like I said, I'll do a tips thing for you guys and I'll send it to you hopefully later today. And then we still have to meet later for lab. So if you haven't done your lab stuff, you could work on that now before we go back into it. And then we'll go ahead and meet, I think, at 12:30. Is that what we've been doing? Right?
Yeah. Oh, so we're coming back at 12:30.
Yes, for lab. Does that sound good?
Yeah.
Yeah.
Okay.
But our lab stuff, you said we still have until like the day that it's due to actually like finish everything, right?
Yeah.
Okay.
Yeah, so you guys see the due dates on there, right?
Yeah, it's usually on Sundays for lab.
Yeah. So I just kept it that way. I figure, you know, you have like a whole week to get it all done. So if you don't get it done on that day, that's fine, you know? Okay?
All right.
All right, go ahead and take a break, and I'll see you guys at 12:30, okay?
All right.
All right, thanks.
Bye.